We have been hearing about diabetes prevention, particularly, when you are speaking about diabetes prevention, we are looking at people with pre-diabetes, how they, how we can look at preventing the progression to diabetes. So that's the major issue that we're looking at. And Madam has highlighted the need to focus on women with gestational diabetes because they are at a very high risk of progressing to diabetes. And also, Dr. Jamal Mehmet sir has spoken about the various strategies that we can adopt towards preventing diabetes epidemic, because he has very clearly highlighted the fact that we tend to have a different phenotype where we are at much higher risk of developing diabetes. So if you look at, I mean, this is what has been already highlighted, that we have a huge burden of diabetes, but the point that I wanted to highlight is that we also have a high burden of pre-diabetes, and that's the group that we are looking at when you're trying to prevent progression to diabetes. And that group, if you look at that group, that prevalence of that group is 15.3%, which is even higher than the prevalence of diabetes. And when you look in terms of absolute numbers, you say that 136 million people in our country have pre-diabetes, and they are at very high risk of progressing to diabetes. Apart from that, they have several other factors that I'm going to discuss about: the risk for cardiovascular disease, risk for other all-cause mortalities also tends to be higher in these people. And what is the distribution of these people? How are these people? I mean, they could be people who have got impaired fasting glucose. They could be people who have got impaired glucose tolerance. Are they the same, or are they little different? So those are points that I'd like to discuss. And if you look at pre-diabetes itself, they are harmful because of progression. That is one factor. The other factor is because of the risk for cardiovascular disease, and the other factor is because of the clinical and metabolic aspects that they themselves have. So if you're looking at the prevalence globally, or it's about more than 550 million people with pre-diabetes. And when you look at the prevalence of IFG versus IGT in our country, based on the INDAB study itself, we can say that IFG prevalence was about 10%. IGT prevalence was much higher, 33% almost. And if you look at the distribution of this of pre-diabetes across the country, I mean the prevalence across the country, you see that there are differences in terms of, areas which have high prevalence rates of diabetes may not have that much of pre-diabetes. They are already people who have converted to diabetes, but there are several other zones of the country, other states in the country, where they have a high prevalence of pre-diabetes. And if we do not target these individuals, they are likely to increase the prevalence rates of diabetes in those states. So that is the point that I would like to highlight here, that there are these pockets which have a very high prevalence of pre-diabetes. The ones in red are the ones which have slightly lower rates of diabetes, and they are the states which over the years are going to have much higher rates of diabetes if this epidemic of pre-diabetes is not controlled. And when you look at the pathophysiological factors, all of the factors that cause diabetes are relevant at that point of time also, or at that point of time of diabetes, pre-diabetes also. But the interesting point that I would like to highlight is that when you look at IFG versus IGT, that is impaired fasting glucose versus those who have got impaired glucose tolerance, they have some differences in terms of how they respond to various therapy, different the strategies, and also what is contributing to that. So if you look at IFG, it's more of liver insulin resistance, whereas in IGT it's more of skeletal muscle insulin resistance. And also when you look at the beta cell defect, it's more of the first phase of insulin secretion defect in IFG, whereas IGT it's more of the second phase of insulin secretion. So these characteristics actually make them little different. And what we see is that, we spoke a lot about and I'm going to speak also a little more subsequently also a lot on lifestyle modifications. Those things work very well for IGT. They do not work very well for the IFG. So IFG, people with IFG tend to have a more resistance to responsiveness, less responsiveness to all these measures that we're going to speak about. So, and the other point that I would like to highlight is that when the other metabolic risk factors cluster along with dysglycemia, then the risk of progression becomes much higher. the risk of problems becomes much higher. Risk for development cardiovascular disease becomes much higher whether when they have lipid abnormalities, when they have hypertriglyceridemia, hypertension coexisting along with that, or metabolism associated steatotic liver disease, as we call it now, MASLD, or non-alcoholic fatty liver disease, which you are very familiar with from a long time, or heart failure. So if these are there, then they add to the risk for progression to various problems that we spoke of. And just looking at some of the data again from Cure study, we just heard about some facts about the prevention of diabetes from the Cures data. So there was a very high prevalence of cardiovascular disease as we progress from normal glucose tolerance to IGT to diabetes. And this is borne out even in the nurses health study. From globally, if you look at the data from across the globe, you see that similar data is seen in the nurses health study, where you see that from normal glucose tolerance to IFG or IGT and to diabetes, you see the very steep increase in the prevalence of cardiovascular disease. And not only cardiovascular disease, we say that cardiovascular disease is increased because the risk factors are there, the cardiovascular risk factors are there, but even retinopathy or nephropathy and neuropathy, which are related to the glycemic control itself, are also increased. There's data showing that this also about 8 to 10% are affected by retinopathy also, and similar data about nephropathy and neuropathy also. And just going back to the nurses health study, I was just highlighting this fact that as you go across the spectrum from non-diabetes to IFG, IGT, and diabetes, you see that there is a steep increase in the risk for cardiovascular outcomes increasing. And there is also data on cardiac autonomic neuropathy in pre-diabetes. So pre-diabetes is not a disease which is innoxious and which is not going to have any consequences, but it is a stage where we need to intervene, and we need to look at how we can intervene at that time. And there are many factors which can even predict whether the individual is likely to respond to all these measures, and we are able to prevent diabetes or not. So progression of diabetes is again variable across different populations, and there are a lot of studies which have shown that in our population we tend to have Indians and the South Asian population, we tend to have very fast rate of progression from pre-diabetes to diabetes. So this was borne out by different studies, where we in one of these studies by Dr. Anjana's data, you see that 78.9% per 1,000 person years amongst Indians, as compared to Caucasians having a rate of about 35 to 40 per 1,000 person years. So a little difficult to understand that, but in terms of simple facts, we can say that this is about 15 to 18% of Indians every year from pre-diabetes progress to diabetes, as compared to 4 to 5% amongst the other populations. So that's the difference, about 3 to 4 times higher rates of progression. And another interesting factor is that the 1 hour value, which has been highlighted again by the IDF also, that 1 hour post glucose value is very important in deciding the progression. So those who tend to have higher 1 hour value, they have a greater risk of progression to diabetes, as compared to those who have a not so high 1 hour value, but maybe having a higher 2 hour value. They may not progress that rapidly as those with 1 hour value. Now let us look at the topic of the I'll quickly take you through the global prevention trials that we have. Most of them have been looking at lifestyle modification. They have been the most effective, but we have a lot of trials with medications also. I'll take you through some of these also. I think the earliest one was the Finnish diabetes study, which had 522 subjects with pre-diabetes who were randomized to either the intensive therapy with diet and exercise, or the standard therapy, and the objective was to bring down the weight by 5% and decrease fat and change the diet to fat of less than 30%, saturated fat of less than 10%, and increase the fiber intake and moderate exercise. All of them did that, about 30 minutes of exercise per day. And what did you see? Of this, you see that there is almost close to 50% reduction in the progression to diabetes amongst these individuals with pre-diabetes. Interestingly, we have data similar data from the Darkwing study. That is a Chinese study, again, which had a large number of patients who were screened in China. And out of all these 110,000 patients who were screened, 577 were randomized to the four arms, rather, diet, exercise, diet plus exercise, and control arm. And what we see is that again a 60 almost close to 50 more than 50% reduction in the progression to diabetes. As you can see, with exercise it was 46%, diet and exercise was 42%, diet alone was 31%. So both lifestyle changes, I mean diet and exercise, are working better, and exercise alone seemed to be better in this group. Surprisingly, exercise alone did better than diet and exercise. So this is something which very difficult to explain that at that point of time. But interesting point is that even when you look at these patients who are followed up, these initial studies were 4 or 5 year studies, but when you look at the 20-year follow-up of the same study, you see that there is still at 20 years the initial group which was on intensive lifestyle modification still had about 51% lower risk of diabetes during the active intervention period. They had 43% lower incidence after 20 years also. So this uh, initial intensive lifestyle change had a long lasting benefit, which is like what we call it the legacy effect, which continues with many of the in what we understood from the UKPD. Similar sort of effect was seen, and even a 30-year follow-up showed that cardiovascular events were 27% lower in the initially treated group, which were treated with intensive lifestyle measures itself. So that is the benefit of starting early and bringing about changes in the lifestyle. And this is the forest plot showing again a significant benefit on all the complications of diabetes, and all cause mortality also was significantly lower in the intervention group as compared to the control group. Now we have interestingly data from the diabetes prevention program also, DPP, which was done in many centers across US. And there were 1,000 patients assigned to three different arms: placebo, metformin, and lifestyle intervention. And what we see is after the initial 4.5 years of follow-up, you could see that there was a reduction in lifestyle brought down the risk for progression by 58%, and drug therapy by 31%, that is metformin by only 31%. And the other interesting thing was that in older people this seemed to be doing better, with almost 71% reduction in the progression to diabetes amongst those older people with pre-diabetes. And as you can see here, the that is graphically shown here. But interestingly, again, the follow-up of this, which was called the DPPO, DPOS, at 10 years continued to show the benefit. And all the participants had those who were in the intensive arm continued to have that benefit of 52% reduction in the progression to diabetes. And and more interestingly, even after 24 years of follow-up from the initial period, so those who were in the initial intensive arm tended to have benefit in terms of all the microvascular complications and also the cardiovascular disease, showing that this initial intensive lifestyle change had a very long lasting benefit. So this is shown in terms of all the complications, like not only the development of diabetes, but the CVD events, the composite microvascular disease, the CV deaths, and the all-cause mortality was much lower in the intensive therapy arm, lifestyle intensive therapy arm. Now the next one is the Indian Diabetes Prevention Program. So this is interesting because Indians, as was shown in the previous presentation by Dr. Jamal Ahmed, was that we have several different risk factors. We have a higher rate of progression, as I just mentioned. So do we have that benefit with lifestyle changes? So this study done by Professor Ramchandran and almost published about almost 20 years back now, this study had again showed a benefit of about 28 to 28% with lifestyle plus metformin. He had a lifestyle plus metformin arm and only metformin arm, and only lifestyle arm, lifestyle, metformin, and a combined. So what we see is that lifestyle and combined showed similar benefit I mean, when compared to metformin, they were better than metformin. But combined, you find that still there was no difference when you added on lifestyle metformin to lifestyle. So the most important observations in this study is that it is possible to prevent diabetes in native Asian Indian subjects with IGT using lifestyle modification despite the relatively low BMI and all the characteristics that we said, high insulin resistance and all that. Metformin is also effective at smaller doses. The dose of metformin used in the study was only 500 milligram as compared to the metformin dose in the other studies where it was 1700 milligram average dose. And the addition, there was no additive effect of lifestyle plus metformin as compared to only lifestyle modification. And the progression rate again was shown in this study also to be almost 55% in 3 years. That is about 18% every year, as I was mentioning, as compared to 6% in the Finnish study. This is in the control arm. So without any intervention, 6% progression in the Finnish study, 11% intervention in the Chinese study, and 18% progression in the Indian study. So clearly showing that we tend to have much higher rates of progression to diabetes from pre-diabetes. Then looking at the medications, several different medications have been used, as you can see in this graph. You have metformin, then you have acarbose in the stop NIDDM trial. We have naticlinide, which has been used. Naticlinide did not show any benefit, but you can see almost 25% benefit with acarbose, 20% reduction in the progression to from pre-diabetes to diabetes with glargine. Then you have got 27% reduction with rosiglitazone and metformin, and then you have 75% reduction with troglitazone. And DREAM trial showing about 60% reduction in the rosiglitazone, and pioglitazone again showing 72% reduction. So the glitazones had the very significant highest rates of preventing the progression from pre-diabetes to diabetes. But again, the effects were easily washed out when the medication was stopped. Other agents have also been shown to have this benefit. Semaglutide, tirzepatide, and DAPA and EMPA also have been shown in various studies to prevent this progression. DREAM study, as I was mentioning, had shown a 60% reduction. So I'll not go into details of that. But this is a summary of all the trials. As you can see, good results seen with very good results seen with the lifestyle intervention studies. The only ones which are standing out tall amongst the drugs are medications are the pioglitazone and rosiglitazone. Liraglutide again is 78% reduction. And you can see now bariatric surgery again is about 83% in those who are obese and have pre-diabetes. Bariatric surgery also shows a significant benefit. So this is a summary of those lifestyle intervention trials and all the pharmaceutical agents. So who requires pharmacotherapy? Now, if you're going to manage patients with pre-diabetes, and Dr. Jamal sir has highlighted the various lifestyle measures that need to be done, what needs to be done about the diet, what needs to be done about the exercise. So I thought I'll just speak about this. Who needs drug therapy? So those who are at high risk of developing complications, those who have multiple risk factors along with pre-diabetes, that is if they have an MASLD or they have hypertension, they have hypertriglyceridemia, they are the ones who probably will benefit from medications. Who are and those who are unwilling or unable to modify their lifestyle, uh, such as osteoarthritis or other things that can prevent their or those who have symptoms attributable to hyperglycemia, they can also benefit. Those who are asthenic or have various other symptoms of hyperglycemia, or those who have comorbid conditions which can be resolved by hypoglycemia. If they have a foot ulcer or something which, or an infection which will benefit from treatment, then I think that is a scenario where we need to start medication. And metformin has been particularly shown to be helpful in when the BMI is more than 35, age is less than 60, because older people tend to benefit more from the lifestyle changes. And women with prior gestational diabetes also probably a group which benefit from metformin. And metformin therefore can be used in those with a slightly higher HbA1c as compared to those with the lower ones. 6 may be a cutoff above which you may treat, 6 or 6.1, whatever that we may use as a cutoff to decide on who gets the treatment versus those who don't get the treatment. So I think I'll just end by saying this is pre-diabetes is the time to act, and we should all be good physicians, just as a Chinese proverb goes. We should try to prevent the disease rather than treat the disease. So with that, I'll conclude. Thank you all for the patient here.